Okay, we're recording. Welcome, everyone. This is March 22nd, 2020. We are doing the webinar Active Surveillance with Dr. Richard Roach from Advanced Urology Institute. And we're also doing it with two active surveillance patients. One is Fred from, I didn't ask you guys if I could use your last name. Sorry, I've been using initials. But Fred from the Village's Prostate Cancer Support Group, and Jim, who I know through our own active surveillance virtual support group, and they both have great stories and they're very knowledgeable, and I think it'll drive the lessons that you're trying to understand by seeing it in terms of their personal stories. That's what a case study is. So I first want to thank our sponsors, and we've got two of them for this webinar. One is a company called Exact Sciences, and let me clarify why they would be a sponsor. They manufacture the test called Oncotype DX. They used to be called Genomic. Dr. Roach, I think you have a little background noise. So that's who Exact Sciences is. And then the second sponsor makes a test called Polaris, and that company is Myriad. So these two genomic tests are tests that are available to men who, if I remember right, and I'll let Dr. Roach comment on that, are category low risk, very low risk, perhaps some favorable intermediate risk. So some men are eligible for insurance to pay for these tests. I believe that Medicare pays and private insurance is case by case, but Polaris and Oncotype DX are two genomic tests you can consider. And we'll get into that a little bit more later. I'm going to keep moving if that's okay. So I want to let you know how we're going to do this webinar. And first I want to tell you what we cannot do. We cannot advise whether you should stay on active surveillance or have treatment. Dr. Roach can do that in his clinic, but he can't do it here. He's not seeing you clinically. Joel and Fred and Jim and I are not medical professionals, so we will not do that. But there's so much that we can do short of medical advice. So that's where we're going to take you today and help you out. We can help you understand your own situation better because every prostate cancer is different. So remember that when you're sitting in the waiting room at your urologist's office, if there's another prostate cancer patient there sitting next to you, he's different than you. The key there is to understand your own cancer because that's all you care about. That comes from a basic understanding of your medical records. So, and we'll talk more about that as we go. Our goal is to help you understand both risk and benefit of doing active surveillance, of considering treatment, or some of the tests. For example, there are some benefits to biopsy, but there are also risks to repeated biopsies, especially. So we'll talk about that. We'll try to clarify for you so you can then develop better questions for your urologist, your doctor. And there's a funny thing that better questions always got me better answers when I did this with my husband for 13 years. One day I just stopped looking for all the answers and started asking myself if I was even asking the right question. That changed my thinking, and it helped me a lot. My husband lived for 13 years after a PSA of 7,096. So I've got to pause there for a minute because I know that's shocking, but it's true. My husband had a PSA of 7,096.0. I got very involved. We did a lot of things on a 13-year journey. He lived for 13 years. So there's a little perspective for you. All of this is meant to help you do something with your doctor called shared decision making. That's a really important phrase that I'd like you to know. It's actually the first section, shared decision making, of the 2017 prostate cancer guidelines for urologists, radiation oncologists, and medical oncologists. Okay, so shared decision making means that you're sharing the decision with your doctor. You are part of the treatment decision. As you develop better questions, you're going to be more content in your journey, and you're going to feel more empowered and less helpless. We are going to do some Q&A today. Again, if you could try to type your question into that chat box or that little icon, I'll try to get to you, and I'll open up your mic, and we'll do some discussion. But here's some things to think about. I have to shorten what I say all the time, think in bullet points, not paragraphs. Figure out the key question, let all the little stuff go. Number 2, take notes while we're talking because your question might get asked or answered before you ask it. Frame your question just a little bit without giving, you know, your whole story. And again, we cannot give you medical advice. So at this point, I'm going to turn it over to Dr. Richard Roach, and I'm going to let him talk about active surveillance as a clinician. He's also Fred's doctor, so they do this journey together. And I'm going to try to pull up slides and visuals while he's talking that correlate with what he's saying. So thank you, Dr. Roach, so much for giving us your time on a Sunday. We all really appreciate it. I'm going to turn it over to you.
My absolute pleasure, Jan. Thank you for the opportunity. So we're basically choosing treatment options for localized prostate cancer here, but our focus will be on surveillance. So a man diagnosed with localized prostate cancer has 3 basic choices: active surveillance, surgery, or radiation therapy, and variations thereof. The choice should be shared between the physician and the patient and his significant others, but it is based on age, stage, grade, general health, and then, as you mentioned earlier, the risk and benefit ratios. So one of the big things used in choosing or not choosing active surveillance is the risk groups. And there's 3 main categories, but 5 subcategories. And I think you have some slides that you can show our viewers that I can't see, but the very low group, very low risk group are cancers that are not detected on digital rectal exams. So when I do the rectal, I don't feel a nodule. The PSA density is less than 0.15 and less than 50% of any core is involved with cancer. So that's your very low risk group. Then the low risk group, the tumor again is confined to the prostate, PSA is less than 10, and it has a grade group of 1, which means the Gleason score is 6. Back up a little here. The full gamut of prostate cancer is the Gleason's grade. Add the 2 grades together gives you your Gleason score. Then they take the score in the PSA and give you a grade group. And then when they roll everything together, they get these risk groups. So with your very low risk and low risk, your Gleason's score would have to be 6, which is 3 + 3. Then there's the intermediate risk group, and they break that down into favorable and unfavorable. So in the favorable, your grade group would be 2, and to have that, your Gleason score would be a 3 + 4. Well, your Gleason's grades are 3 + 4, your score is 7. There's 2 ways to get to 7. 3 + 4 is the friendly way, which puts you in the favorable group. And then the unfavorable group would be 4 + 3, meaning you have more of the aggressive high-grade cancer and less of the little islands of the more intermediate grade 3. And then in the favorable group, usually it's less than 50% of the cores. In the unfavorable, more than 50%. And then your high risk is PSA greater than 20, grade groups 4 and 5, which would be Gleason's scores of 8 up to 10. But there again, the cancer is confined to the prostate. Then you have your very high risk group, and the cancer is extended into the seminal vesicles, which would kick you up to stage T3B, or into the rectum or bladder, which is T4. So when we're talking about active surveillance, it mainly would apply to your low risk groups, stage T1, Gleason score 6, PSA is less than 10. Those are patients, good candidates for active surveillance, or depending on their age, watchful waiting. Now we'll get into more of the fine differences between those 2. Some of the favorable intermediates meaning grade 3+4 on their Gleason grades and scores, and a small enough volume could also be considered for active surveillance. So moving on from just the general different risk groups, grades, Gleason scores and all that, the men with the low risk groups, I'd say at least 30% or more are now candidates for active surveillance, you know, for localized prostate cancer. And they have a slow growing cancer, and active surveillance is actually a better choice than immediate local therapy with radiation or radical surgery. My way of looking at active surveillance, active surveillance is not no treatment. It's a strategy to treat you only if and when your cancer warrants treatment. And some people actually think of it as deferred treatment only if you need it. So we're not closing the door on treatment, we're just holding off to see if you can get by without it. There have been many men on active surveillance go 10, 15 years with less than 1% moving on to metastatic cancer, and actually very few of them that actually end up needing active treatment. I think there was one, actually there's a study at Johns Hopkins that showed only 1% or less actually end up with metastatic cancer at 15 years. So we'll better define what active surveillance is. You are monitored regularly. Some people say only once a year to twice a year. I'm a strong advocate of you should be monitored every 6 months, and that includes a PSA and a digital rectal exam. There's debate whether you should be rebiopsied somewhere between 1 year after your diagnosis up to 5 years. I've previously based that on your PSA acceleration. If you ever accelerate more than 0.75 in a given 12-month period, I get excited and recommend maybe we should rebiopsy. Well, more recently, in the last 3 years, I'm using MRI, which you'll see in Fred's case, to try to avoid needless biopsies. So if there is a bump, well, say they're at that 1 year to 18 month after their initial diagnosis, and under old protocol, we would say, oh, you better have another biopsy now, even though your PSA hasn't changed. Now, I'm recommending a prostate MRI first. And if there's no significant change on that, maybe we can avoid the bad side effects of a biopsy. What else? The other advantage is, so we do see acceleration, or the MRI does say you need a biopsy, and we do a biopsy, and your cancer does advance from grade 3+3 to 4+3 or 4+4 or something. Vast majority of those people, since it's caught so early, will be cured, whether it's with radiation or radical prostatectomy. So again, to review, the people who should choose or consider active surveillance, your grade group 1s, Gleason's 3+3, PSA less than 10, excellent candidates with a low volume of cancer. Selected cases of grade group 2s, you know, Gleason's 3+4, but very low volumes, may be candidates. Some people say, well, active surveillance should only be for old guys. Well, no, there is no right age. You can be in your 50s and active surveillance. You can be 51 and active surveillance may be the right thing for you if your cancer is one of those slow-growing, no-growing cancers. You got to counter that with the younger you are, the greater potential to live longer, and, but we want to preserve quality of life. Especially in terms of urinary incontinence and erectile dysfunction. The flip side of that is the younger you are when you have radiation or radical prostatectomies, your healthier tissue, healthier protoplasm, less likely to suffer the consequences or complications than somebody in their 70s or 80s. And then speaking of age, that's where watchful waiting comes in. This is a more passive strategy. It avoids all repeat biopsies and basically uses non-curative or palliative treatment. So you have a grade 3+3 cancer and you're 83 and your PSA was 8 and then it shoots up to 13. Well, most likely your cancer is alive and well and progressing possibly to your lymph nodes, but those folks opt to just do the hormone ablation therapy at that point and not do repeat biopsies or radiation or definitely not a radical prostatectomy. What else? Well, and the other reason for watchful waiting, despite age, is concurrent serious other medical illnesses. If you have uncontrolled diabetes or significant heart disease or other serious problems, the other problems are going to get you before the prostate cancer, and watchful waiting would be definitely the most prudent thing to do. You did mention the oncotype and the Polaris studies. I've probably done equal numbers of both. Probably the last 2 years I've done mainly the oncotype DX, which our pathologist is favoring now. Prior to that, for 3 years, I did basically all Polaris. And those are genetic tests that help tell you, a grade 3 is not always a grade 3. Under the microscope is how they come up with these grades. I don't assign the grade, I do the biopsy. It's the pathologist who, under the microscope, takes the pattern of the cells and says, oh, this is a grade 3+3 cancer or 4+3 or whatever. Well, genetic testing takes it beyond that and says, yeah, this is a grade 3 under your microscope, doctor, but it's really acting like a 2. Or this grade 3 is really acting like a 4. And that will change a man's choice on surveillance sometimes. If you have a grade 3+3 small volume cancer, and you think, well, I'm going to go active surveillance, but your oncotype DX says, yeah, but you have a very aggressive grade 3+3. That may change your choice for active surveillance.
This is Jan. Can I interject a question here? And we'll get to this a little bit in Fred's because he had one of these tests. But do you find that different doctors just seem to prefer different tests, and it's okay for patients to ask for one or the other? And if I understand right, Medicare tends to pay for Gleason 3+3 for sure, and some Gleason 3+4?
Yes, that's correct.
Okay.
Yes. They won't pay for a 4+4 or a 5+5 because that's irrelevant.
Or even
Those
a 4+3. Not even a 4+3.
Yeah, usually no. 4+3, no.
Yeah.
And again, when 4 is your first number, that's aggressive, and it really doesn't make much sense. So yes, and yes, it is doctor preference. Our clinic will send out either one, but now that we've got pretty good experience over the last 5 years with both, our pathologist, Dr. Maruniak, who's his forte is only prostate cancer. Basically, that's all he does is read out prostate cancer biopsies, some bladder, but mainly he is a prostate cancer specialist pathologist. He now is favoring, for whatever their reasons are, the oncotype DX GPS.
Right. Okay.
And actually, we're going to actually in the near future, actually have it available right in our office, right in his path lab. He won't have to send the slides out anymore. He'll be able to run the study right there.
Okay.
Get quicker turnaround instead of waiting the 2 weeks.
Okay.
So
would you like to move on to Fred's case study or his story?
I would love to.
Let's do that.
Okay.
For all that commentary, that's really helpful. And I was pulling up slides referencing what you were talking about. I know you couldn't see them.
No,
But,
I'm sorry, I couldn't.
That's
I
okay.
hope we coincided somewhat.
No, we did. I think very well, and it'll show in the video. So, you know, I'm here to help, and that's one thing I can be doing right now. So I'm going to let Fred begin to talk through his slides with you. And Fred, you want to take it from here for a while?
Sure, I'd be happy to. I was originally diagnosed at age 69. I was
Fred,
living in Orlando.
you need to get in the center of the camera. You're off a bit. There. Thank you.
Okay. As I said, I was living in Orlando, and I just recently moved to the Villages, but my doctor was in Orlando. I was diagnosed. I had my PSA was at 4.6, and it had gone from like 3.6, 3.7 to 4.6 in a year. So we did a biopsy. He found Gleason 3+3 in one core and assigned a low risk category. So what I did, I had just moved to the Villages, and I went to a support group meeting. And I learned a lot just in that first meeting. One of the highlights was diet. And I gave up meat and I gave up dairy. And I lost 10% of my body weight. I also got this cookbook. I don't know if you can see it, but it's called Eating to Beat Prostate Cancer. And there's like 200 recipes in here. All over
Ricketts.
desserts.
David Ricketts, yeah.
Hello?
By David Ricketts.
Yeah, by David Ricketts.
Yeah.
Yeah, and I mean, he's got appetizers, soups, desserts, main courses. So it's pretty interesting. There's some pretty unique recipes in there, and some of them take a little long to cook, at least for me. But anyway, I decided to stay on active surveillance. And also at that time, my feeling was, you know, my urologist was in Orlando, and I figured 60 miles is not a bad drive. Well, it just so happened that we had a lady speak at our next meeting, and her name was Jan. And she went through her history, and she said, don't be afraid to change doctors if you don't like what you're hearing. And my next meeting with my urologist, I didn't like what he said. He just seemed very matter of fact. He just read from a piece of paper and he hardly looked at me. So I said, that's when I started shopping for doctors. And I ended up with Dr. Roach, and I've been very satisfied with him over the last, I guess, about 5 years now. So I still stayed on active surveillance. We did an MRI back then, and this was, I think, like 2016.
Yes.
Medicare did not pay for it. My insurance didn't pay for it, and I think it was $500, and I figured that's not onerous. I can handle that. So I had the MRI done anyway. It was on a machine that was a 1.5 Tesla. And that at the time was not state of the art. But anyway, it showed a PI-RAD2, which is unlikely for a significant cancer to be present. So I decided to stay on active surveillance, and my PSA was like 3.34.
Okay, Fred, I'm going to interject for a minute. Fred, I'm going to go back up to that other slide, just because I had a couple of questions on here I want to touch on real quick. I did want to show people what clinical stage is, because it's confusing. And Dr. Roach, you can correct me if I'm wrong on this, but when you're staging a newly diagnosed prostate cancer patient, clinical stage has nothing to do with your pathology, nothing to do with your MRI, nothing to do with your other tests. It's only digital rectal exam. So about 3/4 of men are this early stage called T1C. So if your digital rectal exam is negative, you are a T1C. That's your clinical stage. I just think it's helpful for people to understand that clearly. With other cancers, they stage differently. With prostate cancer, newly diagnosed, it's digital rectal exam only. So I wanted to clear that up. Thank you. And then I also wrote a question on here because I had promised that we would talk a little bit about focal therapy. When Fred was newly diagnosed in 2014, Gleason 3+3, 1 out of 12 cores, he was low risk by then, which would be very low risk now, I believe. Would he be a candidate, Dr. Roach, for focal cryo, HIFU, or laser? Without going into too much detail, can you comment on who's a candidate and who's not, and what insurance pays for and what it doesn't?
Well, I'm a strong advocate of cryoablation for prostate cancer, both whole gland treatment or focal treatment. I've been doing it for 20 years now, actually. I was one of the very first ones in Wisconsin to ever do it. And I have done hundreds of focal cryoablations for prostate cancer with, over that 20-year period, anywhere from 89 to 92% cure rates. I'm not as big a candidate of HIFU, but then I have to qualify that I don't do it.
Right.
I do have partners down in Sarasota that do. The roadblock when I send people down for that is, oh, it's $20,000 out of pocket and not covered. Next year, supposedly it's going to get its own CPT code and probably be covered. Just to help clarify the difference, I've always found freezing cancer cells is more destructive than heating cancer cells. We see that, especially like in kidney cancer, very, very different. When you do radio frequency heating of kidney cancer, you get 70, 80% cure rates. When we do cryoablation of kidney cancer, less than 4 centimeters, 95 to 99% cure rates on the same, type of cancer. So I'm just a strong advocate of cryo. Laser, it depends on, are you talking transurethral lasering? Which kind of laser?
Transurethral would be the newest, but in general, we could start by saying it also is not covered by insurance, I believe, and it's probably $20,000, just like HIFU.
Yeah.
And some HIFU, now let me clarify that. Some HIFU is probably partially paid. What the key is here is to ask. I mean, let me get that clear.
Right.
When you're talking to a doctor about focal therapy, ask about price right off the bat.
Yeah.
Yeah.
Your cryo will be covered. I've never had a denial in 20 years on cryoablation. And I can actually chase prostate cancer down. They can have a previous radiation, and the radiation may have cured them in the prostate, but they have a local recurrence, up in the right seminal vesicle. I can go in and spot freeze just their right seminal vesicle.
Gotcha.
Okay. Or if they have a local recurrence in the gland, freeze just that, or freeze the entire gland.
Can you tell us who would not be a candidate for focal therapy in general, in your clinical experience?
One where you can't localize it. I mean, if you can't see, feel, or know where the tumor is,
Let's say I had an MRI and I had 3 different spots. Is that too many spots to consider local or focal?
Well, if all 3 are in the same lobe, you would freeze, like, say, the entire right lobe or the right peripheral zone.
Gotcha.
But no, if you have 2 in the right peripheral zone and 1 in the left peripheral zone, that's not a candidate for local therapy. That's whole prostate freeze, complete cryoablation.
And peripheral zone is the outer layer of the prostate, correct?
It's not the outer. Well, it's the outer zone of the prostate. It's inside the capsule. That's where 80% of your prostate cancers occur, Jan. Where only roughly 20% occur in the transitional zone, which is more your BPH zone.
Yeah.
The zone that wraps around the prostatic urethra.
Yeah.
So that's one of the downsides of lasering or transurethral resection. They remove mainly all the transitional zone, but they don't get the peripheral zone because the fear is you go a little bit too deep and you're into the rectum. And you really don't want to be waving that stool when you're doing a laser of the prostate or plasma vaporization or any resection. So you purposely leave the layer where prostate cancer occurs the most untouched.
Gotcha. Okay. That's really helpful. I think a good way to come at it is, number one, who's not a candidate. I think that is quicker than who is.
Well, one other thing who's not a candidate,
Yes.
any for effective treatment, the gland cannot be bigger than 50 grams or 50 cubic centimeters.
Okay.
That takes it out of the realm of being able to reach the cancer wherever it might be. That's limiting. Size of the gland does limit it.
I find that men are almost never told their prostate size, so I find that I'm almost always telling them to ask about it. So, yeah. So I tell them to ask their urologist because it's on, number 1, your prostate MRI. Number 2, the ultrasound report from your biopsy. Number 3, he estimates when he does your digital rectal exam. But imaging
Exactly.
override the estimate probably. Yeah.
Exactly.
Okay.
Yes, they should know their size.
So it's a great question to ask. So, okay. So Fred, I'm going to go back to you, but I'm going to go in order of date. We talked about this slide. Let's go to May 2015. You had that Prolaris test.
Okay, I had the Prolaris test, and it said I was in the upper category, or the higher risk of the low risk group, if that makes any sense. But the key sentence in that report indicated that if I do nothing, in 10 years, I have a 2% chance of dying from prostate cancer. And I like those odds.
Right.
So another indication to stay on active surveillance.
Got it. And again, we just talked a minute ago about there's 2 different tests. One is Prolaris, the other is Oncotype DX. And those are great questions to ask your doctor. So I'm going to move on to the next slide for you, Fred. Okay.
Okay.
Yeah, I think we already covered Prolaris. Okay, go ahead, Fred.
Okay. Yeah, I kind of already touched on this.
Yeah.
This is the one where I paid for it myself. It was only, they had a 1.5 Tesla and said there was unlikely to have clinically significant cancer present.
So I have a question for Dr. Roach on this and for you, because your MRI showed not only was looking for your cancer, but it also, either that or your biopsy, I'm not sure, diagnosed you with some inflammation, which is prostatitis, and some BPH, which is enlarged prostate. So men who are on active surveillance can have all 3, which affects their PSA and other things. And I'd love to hear Dr. Roach comment on that.
Yes. Okay. Just about 90% of people I get MRIs on, which is 5 to 10 people every week, have all 3. And so to clarify for the viewers, PI-RADs 1 is BPH. PI-RADs 2 is subclinical prostatitis. You have microscopic inflammation without any active symptoms of acute prostatitis. And then your PI-RADs 3, 4, and 5. I tell my patients in PI-RADs 3, if I biopsy you, you'll have roughly a 50% chance of cancer. PI-RADs 4, 90% chance. PI-RADs 5, 95% of those I biopsy will be positive. Now that doesn't tell you the grade, it's just the chance of having cancer on biopsy. So I do not biopsy ever the 1s and 2s.
Right, and I believe it's not recommended by most experts to biopsy 1 and 2. In fact, 1 and 2 would rule out the likelihood.
Yeah.
And help me get right on this. The PI-RADS document doesn't usually talk about BPH or prostatitis. They just talk about the probability of finding Gleason 7, 8, 9, or 10.
Right.
In your practice, have you found that the PI-RAD 1 and 2 is often BPH and prostatitis? Is that what you're saying?
Absolutely.
That's interesting. Okay, so that's clinical experience and expertise. May not find it in the PI-RADS document, but I think that's really interesting. But I think it's important that men know that prostate MRI is pretty notorious for missing Gleason 6 because it's not designed really to see it. So they're trying to find clinically significant. The definition of clinically significant is Gleason 7, 8, 9, and 10.
Correct.
Okay.
But that's why I do always biopsy my PI-RADs 3. Some people would say PI-RADs 3, well, you know, that really low probability. Yeah, it's low, but it's still there. So I do biopsy all my 3s.
Okay. Yeah.
And a lot of what I've learned over the last 3 or 4 years of MRI, we send all our prostate MRIs to Dr. Grubbs down in Sarasota, and he's renowned as one of the top radiologists at reading out male prostate MRIs.
Okay.
That's his forte.
Yeah, and the reason I mention this for people watching this video or listening on this webinar, this is why it matters to have the dictated written report from your prostate MRI. This is why it matters to have your own medical records. The fact that your doctor has them is not good enough if you're trying to develop better questions and if you're trying to do shared decision making. You can pull up your own MRI report and look at your PI-RAD score. It's your PI-RAD score. So get curious, pull out your records, and learn to read a few of the big words. You don't need to understand everything.
Mm-hmm. All my patients going out the door get their MRI reports and their path reports. They don't get a choice. Here it is.
Oh, that's really, I find that to be pretty amazing because we all know that all urologists do not do that. So that's really.
Well, I do. Yeah.
Well, we really appreciate that.
Mm-hmm.
Thank you. So Fred, do you want to, I think we'll move on.
Okay.
Keep moving along unless you want to make another comment on this slide.
No, I think it's time to move on.
Sounds good.
Okay. Come in January 2018, my PSA in a year's time went up about 1 whole point, from like 2.9 to 3.9. That's when Dr. Roach and I decided to have another biopsy, but had an MRI first. And this MRI came back and it said I was a PI-RAD 4. This was done with a Tesla 3 machine. Insurance did pay for this one. And it said small nodule in the right peripheral zone. We did that. We got that MRI report. The size of my prostate stayed approximately the same. It went like from 57 cc's to 58 cc's. So that stayed about the same. I'm taking a supplement that helps to control the growth of the prostate. It's called Prostate SR.
Let me pause you for a minute. We want to make sure not to give anybody advice. Dr. Roach, you want to comment on that this supplement, which is over the counter? Want to be careful.
Yes.
Yeah.
No, that has no bearing on prostate cancer. It's probably one of the most commonly recommended over-the-counter supplements by urologists around the country. It's cheap, no side effects, and 50 to 60% efficacy.
Okay,
so it's pretty harmless and reasonable.
So people can certainly ask their doctor and research it themselves.
Yes.
Okay, but
it will not decrease. It will not decrease the progression of your prostate cancer. I want to make that clear. It only inhibits BPH,
which is enlarged prostate.
Benign prostatic hypertrophy, enlargement. Yes.
Okay, thank you for that.
Mm-hmm.
Fred, I did add a note here that I noticed when you had this MRI that when they do an MRI, if you have a previous one, they will compare to it. But if you have imaging done at a different place than you did previously, sometimes they don't know. So patients, I think it's beneficial for them to know to bring in their previous reports so that this new MRI place, Sound Lake Imaging, could call the previous MRI place and order the MRI report from Sarasota, so they would be enabled or empowered to compare them, because comparing one film to another, one imaging to another, is always a little bit better than one imaging by itself. So it's just a good take-home message for people.
Yes.
Yeah. So go ahead, Fred. I'll pass it back.
Okay. Next up, we did another biopsy, and this was, I think the term is fusion biopsy.
Correct, an MRI fusion prostate biopsy.
Yeah, okay. I came back, I was still a Gleason 3+3. Cancer in 1 of 15 cores. instead of 12, now they take 15 with the fusion biopsy. Still clinical stage T1C. Dr. Roach could not feel any nodules. No evidence of prostatitis this time, but decided to stay on active surveillance. And since that time, my PSA is hovering between 3.3 and 3.5.
If you
And that's where I am today.
Yeah, if you were to guess, or Dr. Roach was a comment, how much does diet and exercise possibly have to do with the stability in your PSA and I wonder if it has anything to do with the prostatitis not being visible a couple years later, because we know that some of those things can help with inflammation. So how important is diet and exercise?
Well, from my viewpoint, it's huge. At least a 60% effect on decreasing your risk of prostate cancer or stabilizing it. And my way of saying it is a heart healthy diet is a prostate cancer healthy diet. So, and Fred went on the perfect diet for it with, basically no red meat and reducing all the fats and stuff and higher antioxidants. So I think it's huge. And subclinical prostatitis is also directly related to inflammatory foods. So foods that are higher in acid, higher in potassium will flare subclinical prostatitis.
Thank you. Fred, you want to close this out and then I'll move on to Jim Sims next?
Okay, well, that's basically my story. I do have a challenge right now. Governor DeSantis closed all the gyms. So
because of coronavirus.
Yeah, and so I have to find ways to do my resistance training. I went out and bought some dumbbells yesterday, and the idea here is I'm not going to be able to do as well without the equipment, but I'm not going to do nothing.
There you go.
I'm going to keep doing something.
Very good.
That's my philosophy.
And do you now lead that prostate cancer support group that you stumbled into way back in the beginning?
Yeah, I'm the lead facilitator. We have 5 facilitators, and without them, I couldn't do my job. They support me very much, and it's an interesting. I'm always learning, and the problem I have is there's so much out there to learn that I can't keep up with it all.
Well, it's same problem for all of us, and it's the nature of science. So it's just, I guess it's a good problem to have. So I do want to put a plug in. If you're in the Villages or close to it, the Villages Prostate Cancer Support Group, and I'm confident in this, is the largest prostate cancer support group in the entire state of Florida. I do speak there every year. I know the guys. They're caring, they're engaged, they're educational. It's a really great group. You can look it up online, but that's a resource for you. They have a meeting first Wednesday of every month, and Fred is the facilitator. So I'm going to move on to Jim.
Hold on, Jim. While you're talking about that,
yes,
I think anybody in the Villages knows that right now you can't have any indoor activities in any of the rec centers
because of
so I'm in.
Yes.
So we canceled our meeting for April 1st, but I'm going to research some platforms and possibly go to meeting like we're on now, and maybe, hopefully, if the center's still closed down, to have some webinar type meetings going forward.
Okay, so they can find that information on your website, right?
Yep.
I will email that to everyone.
Yep.
I'll make a note to do that when I email them after this. There's a Villages website. Okay. Okay, so we're going to turn it over to Jim. He is in Tampa, and he has an interesting story also. And I think stories drive home, messages really well. Go ahead, Jim.
Oh, okay. Well, I am what my urologist refers to as an active surveillance pioneer. I've been on active surveillance for Gleason 6 prostate cancer since my diagnosis, And as of May of last year, my first MRI guided biopsy showed that there was no cancer. Whether there's no cancer or they can't find cancer, I think that's one of the reasons why my urologist says that I've been so successful following this practice, if you will. And, I know it's been a godsend. When I first started, I told my urologist, after I told my wife I wasn't going to do anything, and she says, "What do you mean you're not going to do anything?" I suggested that she read some of the 5 books I read and went to the myriad websites that I used, and she became my strongest advocate. But at the time, the urologist says, "Yeah, I'll work along with you. I have one other man doing the same thing." So back then, there was one other gentleman who was on active surveillance. I've done a number of things that I believe has contributed to the good results. Exercise, diet. I do a lot more fruits and vegetables, a lot less red meat. I've also, I'm in Florida, so I get a whole lot of vitamin D. One of the things I did early on was I had a consult with the nutritionist at Moffitt, and she helped me a little bit in changing some of my diet. But that's pretty much it. I lost a little bit of weight as well, and so I was very interested in getting information when I was first diagnosed. As I said, I read 5 books, went to a lot of websites. Haven't been as active since. I occasionally will read a book, but I consider that I'm very fortunate. I thought that at 73 years of age, I might be moving into watchful waiting, and I went to the urologist the other day. My PSA is 2.8, and he says no. He says we'll still monitor you. We'll still do PSAs. Probably not going to be doing biopsies, but we'll more or less see. And that's my story, and I'm sticking to it.
Can we walk through slides just a little bit? I've got slide 2 up. Can you talk a little bit about what's on here? You were diagnosed 2006, and you've been doing active surveillance for 14 years or 13 years.
Right.
That's a big deal for men to hear. And again, I think this diet and exercise might be a big part of it, but also the expert opinion on Gleason score.
Well, yeah, absolutely. When I was first diagnosed, my biopsy was sent to a lab in northern Florida, and they said that my Gleason was 3 + 4 is 7. And one of the bits of information that I read was that most important thing that you could do was to get a second opinion by a world-class expert pathologist. Little did I know that pathology, as well as MRI, is half art and half science. So one of those half a dozen experts was Dr. Jonathan Epstein at Johns Hopkins. I went to his website. I even called him and spoke to him, and he said, "Yo, send me the slides." I think at that time I had to pay a copay about maybe $200, $250, but he said your Gleason is 3 + 3 is 6. And so even though 3 + 4 now may be considered intermediate, definitely when I was told it was 3 + 3 is 6, that was the thing that opened the door to following active surveillance. And I know that if I go on the internet and go to a website with 13,000 followers and tell them I'm watching or I'm monitoring my Gleason or my prostate cancer, the reaction will be, "What are you waiting for? It's cancer." And I think one of the things that was helpful for me, besides I had been an emergency medical technician working in New York before I moved, was that when I went in to find out the results of that first biopsy, my urologist said, "Mr. Sims, you have a little bit of cancer." And when I guide people or give them my story, I said that I focused on that little bit rather than on cancer. And I think that as well, the way he positioned it and the way he articulated what we were dealing with, that made all the difference. And that urologist, I worked with him for a while. When I wasn't able to do a biopsy or an MRI under general anesthesia, which is just my personal preference, I moved to Dr. Tushar Patel at USF Morsani, Tampa General Hospital, and he is fantastic. One of the things that I was so impressed with him is that he knew my position and my wavelength about aggressive treatment at the age of 71, 72. And he was right in tune with me. And when I send him an email, with 3 pages of questions and I go in to see him, he read every single page. He knows what I was talking about, and that kind of made it a little bit easier. So one of the things that I also suggest to people is to have a recorder with you, whether that be an individual or some doctors may allow you to record the session, but you need to have somebody else keeping track of what's being said, because otherwise your brain won't handle it. Because you hear that you've got cancer and your mind goes crazy. And, you know, unlike other maybe diseases, you're much more a partner with your doctor, and you have to be on the same wavelength. Obviously, you have to respect his or her expertise, but they need to respect you as a person. And I thought that really was evident when I was speaking to my GP, general practitioner, in 2007, and I was asking him some questions about prostate cancer. And he said to me, he said, "You probably know more about it than I do." So, you know, I believe that you need to be educated. You need to educate yourself, and you need to have a plan. So, anything else?
Yeah,
What else?
I would love for Dr. Roach to comment on this one PSA in here. Your PSA was 4 something, 6 something, and then all of a sudden, January 2017, it was 0.8, but we're on Avodart for BPH,
Yeah.
which is a large prostate.
Right.
Dr. Roach, can you comment on that?
I can. That's a more drastic reduction than we normally expect from Avodart. Avodart normally takes your PSA, whatever it is naturally, and literally cuts it by 50%. So 4.6 would normally drop to 2.3. For James to drop all the way down to the point something range is pretty unheard of. That's remarkable. So had to be a combination of diet and regression of the cancer and the Avodart, because usually you only get a 50% reduction. Now, the flip side of that, for all the men who are on Avodart or Proscar, finasteride, dutasteride, those are all for the same thing. Whatever your PSA is, you have to double. So if you come in with a PSA of 2.8 and you're all excited, oh wow, my PSA is less than 4.0, I'm good. No, 2 times 2.8 is 5.6. You're not good. You have high PSA. Okay, and that's something oftentimes missed.
So Avodart and Proscar, and Avodart generic name is dutasteride, Proscar generic name is finasteride. They're usually prescribed to reduce an enlarged prostate. Is that correct?
Yes, they're used to treat BPH.
Yep.
Now, there was one large VA study on finasteride or Proscar that looked at, literally hundreds of thousands of vets taking it, and they saw a 17 to 18% decrease incidence of prostate cancer in the men that were on long-term finasteride or Proscar. That's a good thing. The bad thing was those that got the cancer, it came in always at a higher grade. It came in at a grade 4, grade 5. So it created a real ethical dilemma. Do you want to take a drug to shrink your prostate that reduces your chance of getting prostate cancer by 18%? Great, but whoops, I got it, and now I got a grade 4 instead of a grade 3.
Don't the experts still disagree on what that really was? Some have said that Gleason grading looks different after you've been on Avodart or Proscar, so it's sort of a unknown grade.
It could be.
Yeah.
It could be, but it's still just it threw a monkey wrench in things.
Sure. I don't think it happened with Avodart, did it? They didn't have this. They had the reduced.
Avodart wasn't around during that study.
Yeah, but they did a reduce study, REDUCE later, and I can't remember, but I think
I don't remember that.
Yeah, people can look up the reduce study, and then the Proscar study was the prostate cancer prevention trial, so they can research that. Yeah.
Yeah, I need to add a little bit of fact about my PSA. I like to call PSA a check engine light for your prostate. But in December of 2018, my PSA was 4.8. and the size of my prostate had grown from 51 cc's to 108 cc's. I had at least 2 urinary tract infections and 2 other urinary infections at the end of 2018. And personally, I believe that my
Jim, I think we lost you. Did you hit?
We lost Jim.
Did you hit your mute button or unplug your headset? Maybe he's coming back. Hang on. We can't hear you, Jim. No, we'll wait for him. I do want to. He'll come back. I do want to get to the landing place here, which is that when Jim had his most recent biopsy about 1 year ago, and it was MRI guided, Dr. Roach showed no cancer.
Yeah,
you're not his doctor, so I'm not asking you to comment that way, but have you ever seen that before?
Yes, I have. And, you know, it's, I guess we'd call it spontaneous remission or spontaneous.
Yeah.
The cancer disappears. Now, granted, it could be they just missed it, but in my 30 some years of, you know, doing radical prostatectomies or having them done by partners, we have had people where, you know, 1 out of 1,000, they have cancer at the time of the biopsy. You send the entire gland to the pathologist and he can't find any cancer. I hardly think the biopsy needle took out all the cancer in some of those patients where there is such a thing as spontaneous remission or regression of cancer. And I think diet has a huge, huge role, lifestyle, working out, and all that kind of stuff.
I think it's a great message for people because they always need to know something that they can do. Some days it feels like there's so many things you cannot do, but you can definitely do that. That's a really.
By the way, I'm sorry, I lost some of the transmission. I lost the audio for a while, and now I'm back. So
okay, that's all right.
I don't know what I lost, but I guess you agreed that I must be an active surveillance pioneer.
Absolutely.
Yeah. I also inserted this image, Dr. Roach, you can't see it, but just for people to see, basically when your biopsy report or your MRI is talking about different parts of the prostate, this is just, it's actually an apple, but the top is the base, the bottom's the apex, you know, so there's different zones and there's ways to zone it from top to bottom, inside to out. Sometimes that's of interest if you're really trying to understand your cancer better, so.
Well, it's very important if you're having focal therapy. You have to have it mapped out precisely, not only which side, but do you want your focal therapy at the apex or at the base, or
right.
Yeah, it is critical. And prognosis wise, you're always better off if your cancer's all on one side than both sides.
Right.
So it is, yeah, I give my patients copies of that all the time too.
That's amazing. It's making me smile. A lot of patients don't have that luxury with their doctor. So, I want to go back to the second opinion briefly and just mention that Cancer ABCs has a page on our website, which is cancerabcs.org, cancerabcs.org, talking about second opinions and even second opinions on pathology. So, you know, we've got, Joel has written quite a bit of great information there. Again, he's a survivor of 5 different cancers. So he's definitely an expert in more than one thing as a patient. So any other questions? I'm about ready to close it out, and I'm looking for any questions from the audience. If there's no questions, we either did something really good or really right or really wrong. I hope it's really right.
Jan, this is Jim. I just posted a question about active surveillance in Sweden and in Canada, where I understand it approaches 90% of men who are eligible to be on active surveillance, whereas in the United States, I believe it's 30 to 40% of men who could be on active surveillance. I'm not sure that there's an answer that will allow us to have more people embrace that as doing something about your cancer.
Well, I think what's more clearly the question there is, am I a candidate? And that goes back to the risk categories that we talked about at the beginning of the video. So that's the key. Am I a candidate? What is my risk category? Am I very low risk? Am I low risk? Am I favorable intermediate? Am I unfavorable intermediate? That's where getting your medical records and learning your risk category really helps. So that is a take-home question. Dr. Roach, you want to add to that?
Yes. I think if you look at the social demographics of the countries you mentioned, Canada, is a social medicine country, and I think their healthcare system pushes stronger, whether the patient wants active surveillance or not. I think I can't say this proven, but I think they force it down their throats a little more. They just don't have the healthcare dollars available. They don't have the treatment and the access. I've had several patients from Canada come down to my clinics, especially when I was in Wisconsin, because Canada said, yeah, we'll treat you, but we can't get to you for 2 years. We know you need your treatment, but if you can just wait 2 years, we'll put you on the list. Well, then does that quote go on the active surveillance list, while they're waiting for their treatment?
Right.
So I think the social demographics have a lot to do with that variance. Now, the flip side is in America, maybe we're too overactive in treatment. Green glue, as I call it, that if the doctor recommends a treatment that, oh, geez, Joe, you better get that prostate cancer, that grade 3+3 radiated right away or cut out right away, you never know, for financial gain. And that's sad, but I'm sure it's a big difference when it's a pay-as-you-go system versus a social medicine system. We got both extremes, I think. So.
Yeah, that's really helpful. This has been a great webinar, even for me too. I've already learned just a couple more things, including that last comment. I'm going to close it out unless anybody wants to make another closing statement, like Joel or Fred. Dr. Roach is located in the villages. Dr. Richard Roach, Advanced Urology Institute. That's a quick question from Rich. So
I would just like to take the opportunity to thank Dr. Roach, Fred, and Jim for your participation, and also just have it noted that Jan has done a fantastic job moving us from conference to webinars, and I want to thank her very much.
Thank you.
Thank everybody who's listened in. And Jan and I are more than willing to answer any additional questions by email if anybody has. Hopefully we'll all come out with the new normal. But thank you so much for our participants and also to our sponsors.
Yes.
I got one final comment.
Okay, Fred.
Don't let the old man in.
Who's the old man? Who are,
The virus.
That's who we don't want to be.
oh, you're still young? Is that your message?
Yeah.
You're as young as you think you are? Got it. I like it. Yeah, I'm not going to let any old men in my house. I guess for me, it would be to let the old woman in. So yeah, that works.
I actually might have to apologize. I have my COVID-19 beard that I started growing. And the first time I had a beard was when I rolled over my Mustang convertible in 2013. But my wife says, why you got that beard? It's going to make you look older. I says, it's so I can get into the early bird.
The grocery stores early.
Yeah, right. I like it. No, that's good. So again,
well, thank you, everybody. Thank you for this opportunity.
In the morning without any questions.
Okay. Go ahead, Dr. Roach.
No, I just want to thank everybody for this opportunity. Thank you.
Thank you. It was really great. Thanks to everyone. I will send you a link to the video. So thank you. If you want to send us any emails about what we did right, what we did wrong, feel free. It's always good to hear your feedback. Thank you.
Goodbye.
Bye.
Bye. Bye.